of any kind of, particularly in our case, multi-resistant organisms, so they can put those IPC practices into place very early. Diagnostic stewardship. In the laboratory, they really make sure they maintaining sample quality and having a good quality management system in place, being educated around newer technologies and when to implement them and how to use them, and to support test interpretation. So again, as I said, often particularly newer physicians might not understand some of the microbiology tests coming out, particularly as we're moving more rapid tests with PCR results, with multi-TOF results, with point of care testing for flu, etc. Sometimes they don't understand the meaning of some of these tests or what the sensitivity or specificity are and how to interpret those results. So the laboratory is very good at educating and how we can use our testing and those results better. So as we can see across the different spectra, we're looking at how all these roles really do contribute, although they uniquely different, that collaborating and using these results together and all three domains is really the key to patient safety. And that is the most important thing, so the patients are getting the right drugs, the right doses, changing appropriately when they have new microbiology results coming through, and making sure we're ensuring best care by giving proper IPC practices to these patients. And that an integrated approach yields the best outcomes. So our key strategies for implementation, really when we're looking at implementing different programs, particularly around clinical stewardship, we want clear goals. So if we're doing any antimicrobial stewardship intervention or implementing a new diagnostic stewardship diagnostic tool or a new IPC practice, these are all done in small pilots on wards or for priority infections to make sure that they're working within the hospital environment before they, I guess, too early. Use existing data. So again, we hopefully will have the laboratories producing antibiograms. We have healthcare associated infection logs. And even as we know from an antibiotic stewardship point of view, hospitals have done PPSs, so we have some antibiotic data as well. So using this data to inform how we might improve practices in the hospital, which areas might need to be re-educated if they're doing poorly, and making sure that we have a defined set of data so we can show improvement over time. We want to ensure that key stakeholders are involved, and it's particularly coming from all levels of the hospital, from executive right down to the cleaners. As I said, the cleaners are very important for IPC practices in terms of cleaning of beds after multi-drug snort has been involved. So we're going to ensure that all stakeholders understand new policies, new procedures. We set up multidisciplinary teams, including nurses, pharmacists, and laboratory people, to ensure that all our operating procedures are aligned together and everyone's working together for the benefit of those patients. We do need good leadership support, and as Donna said earlier, good governance, and that is very important for all three domains. We're making sure that antibiotic stewardship, that IPC and diagnostic stewardship are important to the hospital, that these are seen as programs that should be funded, need to be resourced, and we need to make sure that they're working correctly. So we really want that hospital leadership to understand that antibiotic resistance is a very important and timely issue that we want to get on top of, and that between antibiotic stewardship, infection prevention control, and diagnostic stewardship, these are the ways we can stop antibiotic resistance increasing and spreading in our hospitals. We want to define good measures of success. Well, what are we looking from our programs? Are they doing well? How can we improve them? And how can we be sure that they're not actually causing patient harm? So we really look to see how we can define and measure our successes as well as our failures, and make sure we're moving forward and doing the best for our patients. And leveraging existing international resources, tools, checklists. Again, we don't want each individual facility to be doing things from scratch. There's lots of tools and resources out there on how to implement these programs. And I think really, although this is just an introduction, I guess, to these three key themes today, over the next few months, we're going to be going in more detail into each of these strategies to really give some good advice and good techniques on how we can ensure that programs are set up and working correctly. So hopefully in the next few weeks, we can be a bit more specific about all of these different key strategies, but we're just giving a outline today. And as I said, there's many resources out there, the WHO, the CDC, even our own organisation, the National Centre for Antimicrobial Stewardship in Australia, have lots of different resources that you can use, and we'll be going through these in more detail in the coming months. So again, we don't have to start from scratch with these programs. You can really build on what's known out there, what's already been set up, so that we can build on these and make our own programs better. So in summary, antimicrobial stewardship, infection prevention and control, and diagnostic stewardship are shared responsibilities. Integration across these disciplines enhances patient safety, efficacy, and sustainability of the programs. And integration is also key for a sustainable antibiotic antimicrobial resistance response. And only together can we get the best response from our hospitals. Clinical engagement multiplies impact, so collaboration is essential. And start with existing strengths in the hospital. And we've seen in Cambodia, there's lots of strengths. Programs have already progressed fairly well, so we want to make sure that we're building on those successes and not starting again with any programs. That we want to build on our resources that we already have. And as I've demonstrated, every team member has a specific but actionable role across all three domains. And these are all kind of really should be part of their normal working processes. Nothing should be really separate to these. These are all very, very basic things of making sure that the person's on the right antimicrobial. We are obeying our IPC protocols, and that we're ordering our tests and interpreting them the best of our abilities. And this is something we'd all people in the hospital should be doing on a daily basis. So I will stop there and just open it up for any questions or any discussion, particularly if Susan or Donna has anything else to say. I wanted to keep this one fairly short today, and we only have an hour. Hopefully these sessions will be more closer to an hour and a half in the future, where we can have more discussions about specific issues around these three domains. But today was really this introduction of why we are calling all these things clinical stewardship, where it's the integration and all three of these domains working together rather than in silos. And that's what we really want to get to happen. So I will stop talking, but if anyone has any questions, or Susan or Donna, if you want to raise points as well.
Thank you so much, Rod. And លោកគ្រូអ្នកគ្រូមានសំណួរអីទេអញ្ចឹងដោយលោកគ្រូអ្នកគ្រូបានជ្រាបរួចហើយsession នៅថ្ងៃនេះគឺយើងនិយាយអំពីការរួមបញ្ចូលគ្នារវាងតកតងជាមួយ clinical stewardship ជាមួយនឹង IPC ក៏ដូចជា diagnostic stewardship together ហើយយើងបានយល់ថាតើអ្វីទៅជា definition នៃកិច្ចការងារនីមួយៗហ្នឹងហើយយើងក៏បានយល់ពីតួនាទីនិងការទទួលខុសត្រូវនៅតាម core element នីមួយៗនៅក្នុងការទំនាក់ទំនងគ្នាធ្វើម៉េចដើម្បីឲ្យការអនុវត្តនៅក្នុងមន្ទីរពេទ្យនឹងទៅលើការងារ stewardship និង antimicrobial stewardship នឹងបានជោគជ័យហើយនៅក្នុង element នីមួយៗហ្នឹងគឺយើងមាន unique role and responsibility រៀងៗខ្លួនដើម្បីធ្វើយ៉ាងណាឲ្យកិច្ចការងាររបស់យើង contribute គ្នាទៅដើម្បី improve ទៅលើ patient safety ក៏ដូចជា patient outcome ផងដែរអញ្ចឹងខ្ញុំគិតថាលោកគ្រូអ្នកគ្រូអ្នកមានជំនាញខាងហ្នឹងគឺគាត់យល់ច្បាស់រឿងហ្នឹងដែរហើយបើសិនដោយសារខ្ញុំអត់មានជំនាញហ្នឹងទេអញ្ចឹងនេះគ្រាន់ជាការ summary ដើម្បីឲ្យលោកគ្រូអ្នកគ្រូបានយល់ពីវត្ថុបំណងនៃការបង្ហាញរបស់ក្រុមការងារយើងថ្ងៃនេះហើយបើសិនជាលោកគ្រូអ្នកគ្រូឃើញមានជាសំណួរដើម្បីសួរបញ្ជាក់ដោយសារពួកគាត់ជា expert ដែលគាត់ធ្លាប់ធ្វើការនៅខាងអូស្ត្រាលីអញ្ចឹងលោកគ្រូអ្នកគ្រូអាចមានឱកាសក្នុងការសួរគាត់បន្ថែមបានអញ្ចឹងណាអរគុណច្រើន អូខេខ្ញុំឃើញបងសៀងហួយគាត់មានសំណួរនៅក្នុង chat រត់sorry Rod, you have a chat in the question in the chat.
That is probably the most important question. How do we measure our success, and how do we measure we're doing things? I said we will go to, I think, auditing and surveillance and reporting in more detail in future specific clinical NOP sessions. But very, very broadly, auditing. And for hand hygiene, we have hand hygiene audits. We making sure that we are maintaining a level of acceptable hand hygiene within the hospital. For antimicrobial use, we have our PPSs, which we do intermittently to make sure that antibiotics are being used appropriately and for what infections within the hospital. Diagnostic stewardship's a little bit harder yet. We haven't seen too many tools or auditing kind of coming out to see how we're doing with diagnostic stewardship. I think we'll start seeing that in the future. But definitely give some advice on how we improve those. But Donna, did you want to go into more detail about IPC?
Yeah, sure. Thanks, Rod. Yes, there are certainly a range of audits or monitoring activities that we can do from an IPC perspective to see that, and really what they are as a measure of compliance with protocols or procedures. But I would probably add that how would you measure your success? Well, it's probably one of the really important things that you have to do is do some surveillance. Now, this is primarily focused on antimicrobial resistance. So I would assume that if you are keeping, data about your local antimicrobial organisms and things, that you certainly wouldn't see lots of outbreaks. You're either maintaining at a certain level or reducing over time the rates that you see. I mean, there's other sorts of IPC, that's surveillance that a lot of IPC places will do, things like surgical site infection surveillance, central line associated bloodstream infection surveillance, and things like that. Over potentially things that from an infection control committee might set for themselves, certain key performance indicators and things like that that you might set, targets that you achieve. And our targets are usually reducing infection rates, wanting to see low numbers, although with monitoring and compliance, you want to see nicer high numbers, like, hand hygiene or compliance with cleaning. Yeah, lots of things like that. And I think antimicrobial stewardship would be another one of those. I wanted to just also briefly add about with antimicrobial stewardship, when you're collecting data on say surgical site infections and things, one of the things you can collect is antibiotic prophylaxis. That's another data point that infection control teams can often contribute to as well. So how well are you applying the antimicrobial recommendations as well? So there's a range of things that you can look at there. That's probably enough from me.
Susan, I know you'll have a lot to say on here. We've got a short amount of time, but please be brief because we will have a whole session on this. But yep, you've got a huge experience in this area.
Oh, you're right. Wouldn't say huge experience, but I just wanted to say that we keep measuring success quantitatively. So, it's all numbers. And I think even the new WHO, the global action plan on AMR that was just recently released on the 26th of May, talks a lot about behaviour change now, using behaviour change strategies to actually implement or improve stewardship activities across different sectors, not just in human health. So I just also wonder whether you know, before you start implementing or you want to expand your program, that it's worthwhile looking at enablers and barriers, or think about other success factors, such as how many clinicians have we trained. I think that relates to the question that Poland's just asked in the chat. How do you actually empower and get more pharmacists on board to help you do stewardship? So success factors are not just, you know, measurements. You know, it could also be surveys, for example, looking at knowledge and how to maybe change attitudes and perceptions as well. And you can actually do that over time as you implement your different AMS or IPC strategies. And so I don't think that pharmacists need to be clinical pharmacists, Poland, to actually do antimicrobial stewardship. I mean, when we started in Australia, we only had 5 or a handful of AMS pharmacists, and over time, pharmacists just got trained and educated. So if you can become the champion in your country, and then establish training programs or education programs for other pharmacists. It needs to start somewhere, and if you got a champion, then yes, we can just start with that and design, you know, training programs for others. And that's how change starts, right? So leadership, you know, you need to have a committed champion, and if you see yourself in that role, then yes, definitely you can lead that change. And we can talk about that if you like implementation science, how to actually roll out programs and use even different frameworks to measure your success. Yeah, I'll stop there. Sorry, Rod, I took too much time.
No, but I do think, yeah, one of these clinical stewardship sessions would definitely be on behaviour change and how to implement programs successfully. So that will be coming up. Maybe we should have that one sooner than later. So we might look at next couple of months to have that one. So that's very important. There's another excellent question here. How do we build good communication among nurses, doctors, and pharmacists, IPCs, and labs? It's actually probably easier than we all believe it should be. Yeah, because there's multiple ways now we can do it. I mean, it can be as simple as a Telegram group for day-to-day activities, you know, particularly if there's talking about an AMR organism and certain people need to know. And as a Telegram group, you can get information out there quite quickly. We don't like that, it's a little bit impersonal, but for day-to-day and for important information to be messaged, and again, you know, a result can go out, the doctor goes, what does that mean? The lab can say it means this, the pharmacist can add some information around what antibiotics could be used. I mean, we can have that kind of to and fro conversations quite quickly on a day-to-day basis. For longer term and more, I guess, interactive and relationship building activities, meetings should be multidisciplinary. Like if you have an IPC committee, that shouldn't just be the IPCs sitting in a room. You need your pharmacists, you need your laboratory technicians, you need your doctors, you need someone from clinical governance or the executive with ownership on those. And those meetings should generally be multidisciplinary. If you're creating new standard operating procedures, if you're doing new standard treatment guidelines, all these type of things, all the AMS activities, it's really important a multidisciplinary one. I mean, infection prevention control is one of the most important, and that's one we often do see being very multidisciplinary. And I think that kind of helps. And then just the day-to-day things, we can set up little groups, smaller user groups, smaller meetings to iron out some of these issues as well. we can discuss about those. I think these are all very, very good points we can bring up in future meetings. I am a little bit conscious of time. Today's, as I said, it's a bit of a shorter one. We'll hopefully have these meetings be more interactive when we go into the more in-depth conversations. So they'll hopefully be longer, and we'll have more interesting topics, more specific topics, where we can kind of have some good communication as well. But I think we'll probably leave that today. Bandrith, anything else we want to say?
Actually, I don't have anything to say. I just would like to say thank you to our participant for actively participated and have the question. It is quite a good question, and to clarify and understand with each other regarding to the communication regarding how to improve themselves to be a clinical pharmacist and how to measure their successful in the antimicrobial stewardship implementation, something like that. And I think that there is no other question, and our session today is 1 hour already. And I would like to say thank you to everyone for participate today, and also thank you to our expertise, Dr. Rod, Dr. Susan, and Dr. Donna for joining this session. And I hope that everyone get something new from this session. The knowledge of the day, at least we get something. Thank you so much everyone for joining, and I hope to see you all in the next session, and we will inform you before